Good morning. Welcome to PI Today with your host, Dr. Nicholas Aloy. I'm very happy to be back on the show. Today I have a very special guest, probably a subspecialty that most of you have not really heard of. I'm like a gopher. I go out there and try to find the best of the best and bring some knowledge to you guys. So perk up your ears, sharpen your pencils, take some notes because this is one of the main physician doctors that you would need in a traumatic brain injury or even other catastrophic types of accidents. Today, we're going to talk about the eyes and neuro-ophthalmology. This is a very huge deal because, as we know, the eyes are not just the pathway to your soul, they are for you to function daily. So, without further ado, we have Dr. Nafiseh Hashemi MD. Doctor, welcome to the show.
Thank you. Thank you for your kind introduction. Yes, I'm neuro-ophthalmology. So lots of people, they don't know what is neuro-ophthalmology. That's a subspecialty that you can go from ophthalmology or neurology, and we need to know everything about the eye and brain and connection and the visual system. So definitely, if there is any trauma to the eye or trauma to the brain, that can affect the vision and peripheral vision and the function of two eyes together. That's why it requires a very in-depth exam of not only the eye, looking at the scan of the brain and checking the peripheral vision, checking eye movement. It's a very extensive eye exam that requires hours in the office.
That's amazing. And you were telling me in your subspecialty, how many are there in the United States that have your subspecialty?
So we have around 700 in United States, and throughout the world we have 980 neuro-ophthalmologists. We are a rare subspecialty because it's kind of difficult to know everything about eye and brain and the things that can affect eye and brain. That's why it's not popular as far as going through that education because not everyone want to have that kind of ongoing education for years and years and years. And it requires a lots of time, a lots of precision, and so we are like detective of the unknown eye problem or vision problem. Lots of time patients come to us as a fourth or fifth consultation because the other doctor cannot figure out what's going on with them, why they're not happy with their vision and they cannot function properly. And we are kind of detective to look at everything and all of the possibility to find out what's going on and how we can help the patient.
That's correct. And I'm happy you said that because in my practice before, somebody would come in with a traumatic brain injury or some sort of blow to the head, and everybody's heard about VNGs and some sort of ocular type of testing, but what I didn't know that this specialty existed back then. I'm so happy that I do know now because they had imbalance, they had blurred vision, they had they couldn't even sensitivity to light, and I never contributed to the eyes and eye. Well, I should say the pathway from eye to brain or brain to eye, and back then I was much younger and less experienced. But you guys are definitely one of the main doctors in these traumatic brain injuries because these patients are their vision is impaired
Yeah.
somehow. And can you kind of tell us the relations between the brain and the eye?
Yeah. So with the eye, we only get the visual information, right? But the brain responsibility, the brain job is interpret what we get with the eye. So if someone has a perfect eye and on eye exam we don't find any problem, but on the occipital cortex there is a disease, there is an injury, bleeding, contusion, trauma, tumor, whatever. So and the occipital lobe cannot work, then that person with that perfect eye exam cannot see. That's why we need to understand the pathway, and it's not only globe and the occipital lobe, everything in this between. We talk about visual pathway, visual radiation, occipital cortex, and all of the things in between can affect how the patient can function and how the patient can see the world around it.
Correct. Yep. It's very, very interesting. And how is what are some of the things you do to diagnose and then treat non-invasively and invasively, surgical and non-surgical? What are some of the symptoms? What are some of the diagnosis? Kind of, educate us.
Yeah, sure. When we talk about the injury, it can be as superficial of having a bruise around the eye or a little bit of subconscious hemorrhage, a little bit of bleeding inside the eye that can come from like bursts in a small capillary. So, or it can be as bad and extensive of like corneal rupture or globe rupture that requires immediate attention, and we need to take the patient to surgery to repair the cornea or repair the globe. And also we need to pay attention to the bony wall that protect the globe. So, around the eye, we have these bones that holding the eye, protecting the eye, and there are eye muscle that help the eye to move. So when someone has injury, if that injury can affect the bone, of course the eyeball can go back in. We call it an ophthalmos, and then when you look at the patient's face, it's not symmetric anymore. So one eye can be pushed back, the other one would be in place. Or sometimes if there is bleeding behind the eyeball, that eye can start protruding, and we call it like exophthalmos or proptosis. And these are all emergency, because if there is a bleeding behind the eyeball and we don't pay attention immediately to bring the pressure down or to drain that bleeding, so definitely the patient can lose vision, because that bleed around the optic nerve can compress the optic nerve, and also the high pressure that is caused by that bleeding can cause vision loss. And aside from the injuries that can be apparent at the first day that you see the patient, there are some injuries that on the first day or even first week you may don't find it, and it can appear later on. For example, if that contusion on the eye can cause damage to the angle of the eye, draining angle of the eye, the patient can develop glaucoma, which can happen days or weeks or even years after trauma. And lots of people don't pay attention and don't follow the patient enough to see if they got some injury to the draining angle of the eye and what's going to happen to them later on. The other thing is sometimes because of that contusion or that trauma that patient gets, like as a blunt trauma, the patient can develop traumatic cataract, which is a specific kind of cataract that the patient gets, and it can appear weeks or months after, and it requires attention. Or the other things that can happen, the pupil that is supposed to be circle and it's supposed to react to the light, and when you look at distance, the pupil might be a little bit more open or more dilated, and when you look at near, the pupil can get constricted. But if something happened to that pupil during injury and you get a sphincter tear and the pupil becomes irregular and not responding properly to the light or near reflex, that can cause problem with the vision, and it can cause blurry vision when they look at near. These are the very detailed that we need to pay attention during eye exam, And not only the first day or first week after injury, later months after injury, because not everything would appear immediately after injury. And also, the other thing that we need to talk about is the injury that a patient can get to the brain. So sometimes after trauma, patient gets head bleed and intracranial hemorrhage, contusion, like the brain can get injury that it cannot be very obvious with the CT scan or MRI, but the function of the brain and all of those neural connections can get messed up,
Yeah,
and
pathway changes.
exactly
Yes.
pathway changes, and patient can get more problem with understanding of visual information. For example, if you on the because of the trauma, if someone gets injury on the occipitoparietal, like this area of the brain a little bit to the back, so they can lose vision on the other side. For example, on the right side, the trauma is on the right side, but they lose vision on the left side. And when we do the visual field test in the office, then we can find out what part of the peripheral vision they're losing. And unfortunately, some of these patients, they cannot drive anymore because the requirement for driving is not only central vision. Your central vision can be still 20/20, but if you lose the half of the vision on one side, legally you cannot drive anymore. So that
Got it.
makes it very scary, and it's we always have a very difficult conversation because the patient can be 30 years old and cannot drive anymore. How you can function here without driving, right?
And can it be sometimes some of these diagnoses are missed because it can be gradual from the inception from the accident, and then it gradually starts, the onset starts being gradual. So there might not be a big deal at the beginning, but then the vision and the vision problem starts accumulating 6 months down the road,
Yeah.
12 months down the road. And that's why, the visits and the checkups are so important.
Yes, exactly, exactly. Especially when it comes to glaucoma that comes from the injury to the angle of the eye, or cataract, traumatic cataract. These are the things that might not appear the first day or even first week or first month, and down in the road the patient can get this problem. That's why it's so important to look at the patient. Of course, first aid is very important for all of those emergency, for globe rupture, for fracture in the orbit. But beside that, we need to follow up with the patient. Sometimes they do a CT scan first day that the patient has like car accident or any injury. They don't find anything, but then patient comes and say, oh, I get double vision, and my double vision is getting worse because now they're, the shock of the trauma passed, and the patient start looking and working and looking at computer, and now they see there is a double vision, there is a shadow next to whatever they see. And then we re-examine the patient and we see one of the muscles is stuck, it's not working properly, or it doesn't move fully. So, and that's because the muscle got stuck in the fracture that they missed first few days because there was some swelling, and for some reason it got missed, and that require surgical intervention. For example, if it's a nerve palsy and patient cannot move the eye, sometimes we have to wait up to even 1 year to see if the function comes back. And in this between, we have to give the patient prism glasses, which means, if both eyes not moving together and the patient gets double vision, let's say one eye is in or one eye is out, so we put a prism in the glasses to bring the image to the eye, because eye cannot go, let's say, in. We put the prism to merge the image and put it on the eye, and then patient doesn't get double vision. We give the patient prism glasses, we monitor them, and after 1 year, if it's still, the pulse is still there and it's not gonna get better, then we have to do surgery on the muscle. So to make the muscle more stronger to be able to move at the same time with the other eye.
Got it.
So these are the things that require long-term, monitoring
Monitoring,
and
yes.
eventually surgery. Or I have many patients that I see with the traumatic cataract. First is small, and I tell them, "Oh, you still can function, you still can drive." And after 1 year or 2 years, they no, you cannot see, or she cannot see anymore. Then we take them to OR and we remove the cataract.
Got it. And if it's on a severe level of traumatic injury with bleeds, you co-manage with the neurosurgeon.
Yes.
That's the type of physicians. Any
Yeah.
other type of physicians that you co-manage your
Yeah,
practice
we
with?
work with neurologists very
Neurologists. Okay.
closely because, after TBI, lots of patients get headaches.
Got it.
And interestingly, the type of headaches is very similar to migraine. So everyone after trauma gets some sort of headaches, and usually after 1 month or 2 months, it get better, but not everyone. Some
That's right.
people, their headaches last to 18 months, 24 months, and we need to give them medication. So I usually start with mild medication like vitamin, like magnesium, riboflavin, this kind of thing. And if it still persists, then we go on a higher level of medication and we start the medication for migraine. Sometimes they don't respond to this medication and they come back to me and I do Botox for migraine. So that's one of the things that I do every 3 months. I do injection, and that those kind of injection is on the forehead and on the temporal area and even on the shoulder because of all of this muscle spasm. They get severe headaches, and we do Botox every 3 months to help them with these kind of headaches. So, and this is something I work with neurologists because sometimes they need some sort of intervention, like a block in their head or around the face, and I don't do those kind of things. Or if they need the medication that is like more kind of more stronger medication that can have side effect, I would ask neurology to help. But as far as the regular medication or like Botox injection is something that I would do. And also with neurosurgery, we work together, and if they need any intervention that they believe that can affect the visual system, they would ask me to do a visual field test as a baseline, and they go ahead and they do the treatment, and then we monitor the peripheral vision, and if the patient needs to have a special glasses or anything, we can help with that.
That's wonderful. And the most important question of the day: where's your office, doctor? Where are you located?
Yeah, my office is in Encino, Ventura Boulevard in Encino, and so the name of office is my name, Hashemi Eye Care Neuroscience Institute, and we call it Neuroscience and Research Center because we do some research about some of the eye disease that is not related to trauma, but it's a very rare disease, ischemic optic neuropathy, and unfortunately, there is no treatment for this kind of optic nerve disease, and we're trying to use some investigational medical device and to see if that's going to help with this category of patient that they don't have a treatment
That's
for.
amazing.
Yeah.
Amazing. Well, I want to thank you for being on our show, and we'll love to have you back again. I know we can talk hours about this special and rare conditions, things that happen. So thank you again, Dr. Hashemi, for being with us.
You're very welcome, and it's an honor to be in your show. And I think this show really educational, and it can help lots of patients in different level. And thank you for having me here.
I appreciate it. Thank you, doctor. And guys, I hope you've learned some things today. I know I have, and we'll see you next week. Have a great day.
Thank you.